Hi everyone, my name is Amna Multani and I'm a second year medical student from Kansas City University. I conducted a retrospective observational study on the topic of the effects of coronary artery disease as a pre-existing comorbidity on sepsis outcomes. So sepsis is a life-threatening organ dysfunction that occurs in response to infections and causes an astonishing number of 700,000 cases every year, along with 200,000 deaths. It also is the #1 cause of healthcare costs in the United States with a $16.7 billion cost annually. Given the high prevalence and fatality rate of sepsis, it's very important for us to identify patients who are at a greater risk of mortality due to sepsis so that we can direct our care and resources that are quite limited to these particular patients. No studies have previously investigated if sepsis outcomes are influenced by pre-existing coronary artery disease or CAD as a comorbidity. So therefore, we chose to focus on CAD, which is the most common form of chronic heart disease. The goal of our research was to fill the knowledge gap and investigate the influence of CAD as a chronic illness on patient outcomes of sepsis. We hypothesized the mortality rates would be higher for sepsis patients with CAD as a comorbidity. So our study was a retrospective study design where we collected data from a rural Midwestern hospital in Joplin, Missouri, and then we identified patients who had sepsis without CAD and who had sepsis with CAD using ICD-10 codes. And we then compared the mortality rates of sepsis patients with and without CAD using some statistical analysis. So based on our results, we did not find any differences between the two groups. The presence of CAD, it did not seem to affect the mortality rates in sepsis patients. The mortality rates were also similar between different age groups as can be seen on the graph here. And it was also similar between males and females for the two groups. So there may or may not actually be differences, but we certainly did not detect any with the evidence that we collected. There were a couple of limitations which can explain the results that we got. So we did not account for all of the different comorbidities other than CAD, which can be affecting sepsis outcomes. So in future, we can definitely analyze how CAD interacts with other comorbidities to affect sepsis outcomes. So we can focus on comorbidities like diabetes or HIV, because we found that CAD alone certainly does not influence sepsis outcomes. Another limitation was that our patient data came from a single rural Midwestern hospital, so it's unclear whether or not the results that we got could be generalized to the US population. And this could easily be overcome by increasing the sample size and including data from multiple hospitals from urban and rural settings. Another limitation was that we only focused on CAD patients without angina. It would be interesting to see if presence of angina with CAD affects mortality due to sepsis. And that concludes my presentation. So thank you so much for listening.